She said we're alive. We're alive, I believe.
Hello, my name is Brad Lund. I am the Executive Director of the Healthcare Business Management Association. And today we're going to focus on a member benefit that's coming out of our Commercial Payor Relations Committee. Today I'm delighted to be joined by Olga Khabinskay, who is the chair of the Commercial Payor Relations Committee. We call it the CPR Committee. Uh, and we're going to talk about a number of different things, but we're going to focus first on the payer reporting tool. Olga, could you tell us a little bit about that tool and how it works and what the value of it is?
Absolutely. Thank you, Brad, for introduction. Happy holidays, everyone. The tool is amazing. It truly has helped my business to succeed, and I'm sure it's going to help. It is helping other HBMA members with dealing with denials, dealing with insurance companies that are incorrectly denying claims, either professional side, Medicare line of business, Medicaid. It's a great tool that allows members of HBMA to log in online and to report individual claims using the data service, using the denial reason to inform HBMA staff at CPR committee to help them deal with specific payers. And by gathering this data, we have a great set of data now to go to Aetna, to go to United, to help us understand why these claims are being denied and to simplify denials from happening in the future. So it's a great tool that allows billing companies to deal with the denial on a completely different level, much higher level, more exclusive level to HBA members. And the tool is available online. You can log in at any time. It's a Sunday, it's a Saturday, it doesn't matter. Welcome to submit your problems. We gather the data and submit it to payers and get the solutions out to the HBMA members.
And have we been able to achieve any solutions via the information we're getting out of the tool?
Yes, we were successful with delivering results on Aetna claims for different tax IDs. So it's several different billing companies that are HBM members have reported issues specifying the tax IDs and denial reasons. We were actually able to see global issue when it became to behavioral health and imaging claims. So it played a great factor identifying problems on the global level as well. So yes, we did deliver results.
Wonderful. That's impressive. Thank you. Let's focus a little bit more on the general purpose of the CPR committee. Which insurance companies are you working with at this time?
Today, CPR is actively working with Aetna, United Healthcare. We are also teaming up with Cigna and Humana and trying very hard to get Anthem on our side. It's been a project for a few months, but we're going to get there. 2024 looks better and more promising. So it's 5 payers at this time, and national payers is our aim because it's easier to bring our members to the national level and to deal with problems that arise from billing. So far we have these payers on board.
And how can you explain in a general sense how you're working with these commercial payers?
So we have a dedicated team on the payer side that speaks to us on quarterly basis. They listen to our feedback, they ask questions, they reach out to us directly for specific tax IDs or issues that our clients have. They team up with us on webinars to simplify our processes as billers. Either it's the training videos, a training session of where we could go in to get additional help through a webinar portal. So it's a lot of different ways we are building up a relationship with the payers that we never thought would be possible, because so far as billing companies, it was all about customer service. Now we're speaking to live, dedicated representatives that are here to help HBMA members.
You know, when I talk to members, oftentimes I hear them have a very negative opinion of the commercial payers.
Yeah.
I heard once one member say to me that the commercial payers are really good at collecting premiums, but they're really bad at paying claims.
And denying claims.
Denying claims, yeah. In your work with the commercials, are you finding them to be receptive to the issues we're seeing and that they really are serious about helping resolve them?
I believe HBMA reached a certain level of prestige and a relationship with these particular payers. They're looking forward to helping us. They want to understand how they can simplify our problems so that we stop calling the provider services and the customer line. So it's a team effort that's going to, decrease administrative time, and simplify the process for everyone from all sides. So yes, we are very proud to reach the level what we had with HBMA to get the payers' attention and the resources the payers is giving our members.
Okay. Let's talk about a couple of the commercials that we can get more specific with. I understand that you're working with Aetna, and you mentioned the call centers, that one of the primary focuses of that effort or program you're doing with Aetna is to reduce the actual calling into Aetna to resolve issues. Is that working? Is that helping?
Yes. So Aetna has, over the last year, has created so many help options to providers and billers. Either it's the webinars they're hosting, it's the email communication they have improved, either the availability portal they're allowing to customize to improve the communication method. So there's so many different ways that have changed from comparing the beginning of 2023 to now. We have so many different solution methods where we don't need to call. We are simply using the resources Aetna has made available for us.
And how does that work exactly? Are you communicating with them in some kind of an online portal?
We can communicate via our online portal. With HBMA, we have these meetings and we let our members know of the feedback Aetna gives us through our newsletters and the updates that we're sending out. But sometimes it's even through emails. We have success where one level at Aetna has connected us with a different executive regional team to help a different provider in a different state. So it's really working with every single level at Aetna. It starts usually with an email because customer service just deals with review of received claims and giving feedback on the claims. Mm-hmm. When it comes to higher level denial, we need to actually speak to a representative who can look at the policies, make the decision. So it's an effort of both things.
Wonderful. That's great news. Now, I understand that United Healthcare has recently rolled out an API tool.
Mm-hmm.
Again, I haven't touch base with you on this, but are you familiar with that API tool and what value it brings?
So United Healthcare held a webinar with all of the HBM members and part of our CPR committee as well. It's an interesting approach. It's definitely going to revolutionize the way we work with data sets and how we process denials. So there's a lot of interpretation of data methods now available through United Healthcare. It combines EMR, the clinical side, it combines the denial, it combines United Healthcare policy. I think they're at the beginning point. They're still testing out the waters because there's so many regions United Healthcare covers, and every region has their own policy. So there's a lot of things that need to come together for it to work perfectly, but it will, because AI is meant to reduce a lot of issues we're having when it comes to billing and identifying problems. So we're going to be very advanced when it comes to, maybe even next year already, looking at the CPT code, looking at United Healthcare plan, and finding out immediately if the patient is eligible and the claim is going to get paid. That's the perfect role we want to see.
How about Cigna? I know that they did a presentation for us, but I don't recall exactly what tools they're deploying. Are you aware of any?
I think Cigna just did an introduction for us that this is the direction they're going to take, but I have not seen anything yet being offered to us or to the providers how to work with it better.
Okay. This is a question that probably we're not going to have a lot of information about, but our Government Relations Committee is working very diligently on the No Surprise Act and the arbitration issues and all that. Are the CPR committee doing anything with commercials on the No Surprise Act yet?
This is definitely a topic that is brought up to all the payers we work with because we wanted to hear the feedback. We wanted to hear the education webinars that are being offered to providers that are billing out of network. We wanted to make sure if there are any additional forms that are available to the provider. So each payer is aware of the rule. Each payer is addressing the rule. It's always in their newsletter. We are discussing it because many of us do work with providers that are billing out of network. And it's a matter of proper communication. So every single payer has given us enough information to work with to be able to properly handle No Surprise Act when it comes to in clinical practice.
Okay. Now, this isn't something that the CPR committee really deals with, but we were talking earlier, and if I could put you on the spot, you were talking to me about uh, post-payment audits
Mhm.
from the commercials. What is that all about?
So post-payment audit is when the pair made a payment and they have 7 years a right to go back and investigate the payment they made, whether they're checking the medical necessity. But I want to make sure the appropriateness of that payment being made. So they request medical notes, they review medical notes, and they send their decision. Decision could be a negative decision where they do not agree with the medical decision making and they're requesting a refund of the payment. And every insurance company has its own vendor they work with. We hear it's Safeguard, Captivity. There's so many different vendors that insurance company contract with for the period of 3 years that investigate providers and request these notes and overpayment requests. We always work on our side when we get those requests with our auditors because we want to get a second opinion. I don't want my clients to pay back. I want my clients perform the services, or any doctor has performed the services, so they need to understand the reason behind the insurance company requesting overpayment, what policies they're utilizing. Are they looking at the Medicare side? Is there a Medicaid side involvement? So we'll look at the policy, we'll look at the way the documentation was performed, was everything properly done for the patient care, was there authorization, eligibility checks, a lot of different components to finalize an appeal, because we always appeal insurance decision. And if we need to, we take it to the hearing level where we have a peer review by another coder independent of us
Uh-huh.
to show necessity. So there's different ways to get it done. And most of the time, doctors prefer actually to pay back immediately. They don't want to deal with paper trail. We are completely against it. So we come back and say, hey, we're going to offer you help. You need to fight this. Because as soon as you reach an agreement with an insurance company and they felt that they have educated you on your clinical documentation, they will not come back to you for at least 3 to 4 years. But if you're constantly paying back their request, they're going to be coming back to you for the rest of the payments.
Hmm.
We stay focused on providers and making sure that they are compliant with what they're doing and meeting the requirements, and keeping the copies of all the policies, because once the policy is replaced, you can't go back to a document. So we actually keep archives every year of the policies that have changed. That's a great recommendation for anybody who's in audit.
Great information. Which brings me to another question I know you're very familiar with, and the revenue cycle management companies oftentimes talk about this as a real pain point, and that is there's a lot of different terms for it, but credentialing, it would have to do with not only the fee schedule, but contracting, that whole credentialing thing
Mm-hmm.
that the RCM company has to help the practice when new physicians come on into their practice to get them credentialed with the
Yeah.
commercial payer. Can you talk a little bit about that?
Sure. So in order to do billing, we have to bill credential providers. So we are we have to get the doctor credentialed. You need an effective date to get them enrolled, to be recognized by the payer. Otherwise, they can't see the members.
Hmm.
Many payers are very specific. You cannot see a patient, especially if it's an HMO plan, without being a participating provider with that insurance company. So there is a 3-month process, sometimes longer, depending on the specialty, depending on the accreditation. But typically 90 days, you get things done. You get an effective date, provider ID. And then in 3 years, that same contract is due for recredentialing. So you're going to go back and refile some of the papers. But at least once you're approved, you're ready to submit claims, get the fee schedules that the insurance company agreed to pay you. You can negotiate your rate. So there's a lot of work done in the credentialing process that is important for RCM companies to follow, because it's all about what the doctor has an agreement with the payer. If they're paying by the requirements, if they're paying the same rates, you can always go back and check. So
Hmm.
credentialing has become a vital part of our services, and I think many RCM clients, RCM members of HBMA will agree that we used to offer just billing. We're now doing credentialing as well because it's important. It affects our claims. Our claims are not paid if we don't if we are not aware of the credentialing process. So everyone is kind of in the same boat with credentialing.
So I have to ask this question when it comes to the fee schedule. That's a pretty important aspect of it because that determines how much the physician is going to get paid. What tools do you use in terms of making sure that you maximize the fee schedule your physicians get?
So we use our experience and our history of different years. So we kept a library of fee schedule rates from the first time we opened our doors in 2001. So we have a good data to compare the fee schedule increase and decrease as it goes every year. We try to keep up to the CMS level of rates. So either it's 80% of Medicare rate, which is the best. Often it's 74 to 78% of Medicare rates that we try to keep. And also depending on the cost for the clinic. If it's an imaging center, if it's an urgent care, ambulatory surgical center, their cost is much higher. We need to look at the rates before we'll commit to an agreement. We need to negotiate the rates. What if, I mean, during COVID, this is something that everyone was doing it. Give me better rates. My supply costs more. So we're looking at many different factors. So it's the specialty, it's the state, and it's the cost to run the practice. And if there's some kind of unique component to the practice. So, for example, translators, right? With the war in Ukraine, a lot of Ukrainians came here. There's constant influx of immigration in the United States. Translation services became a vital factor. Am I hiring an outside company to do translations? Am I using my staff? Is there an additional bonus for this from the insurance company? So there's a lot of stuff that are coming in. Telehealth is one of the examples, right? If I'm utilizing that. So rate determination has to do, again, with the specialty, with the current rate, with the state, and overall expenses for the practice. And if it's a brain surgeon or a specialist that you don't really, it's a rare specialist, I want to get a definitely good rate, maybe even a triple Medicare fee schedule. So we really look at many factors, and we do have providers who have declined signing an agreement, which would mean they decline taking this plan, and they are a network because they're not happy with the rates. So rate is a great player when it comes to specialty care, especially.
Wonderful. Well, we've run out of time, Olga. I appreciate all the information. You are a wealth of knowledge. And we are so grateful and so lucky to have you as the chair of the CPR committee.
Thank you. And we're looking forward to bringing on members to CPR. So definitely feel free to apply, and we'll welcome you as part of our family. Thank you. Happy holidays.
Happy holidays to you.
Take care. Bye-bye.
Goodbye.